So this is a cellular pathology podcast on respiratory disease. I've decided to divide this up into two parts. In the first part, I'm going to talk about the very basic physiology that's necessary to understand respiratory disease and some of the end pathways. And in the second, I'm going to look specifically at the diseases of the four components of the respiratory system. These are the pulmonary blood vessels, the airways, the lung parenchyma, and the pleura. So first I'm going to talk about some basic physiology. The lungs are the organs of gas exchange, and this occurs in tiny thin sacs called alveoli, where inhaled air comes into very close contact with capillaries of the lung. Alveoli are connected to the outside environment via two sets of airways. These are the conducting airways, comprising the first 16 generations of airways, including the bronchi and bronchioles, and the ventilatory airways, or acini, which is the portion of the lungs distal to the terminal bronchiole. Each acinus comprises the respiratory bronchioles, alveolar ducts, and the alveolar sacs, each of which gives off an increasing number of alveoli. Histologically, the entire respiratory tree, from the nasal cavity to the respiratory bronchioles, is lined by a pseudostratified epithelium consisting of three epithelial cell types. These are ciliated cells, mucus-secreting goblet cells, and neuroendocrine cells. All three of these cells are derived from basal cells. So there are a number of end pathways that are conserved through all of the respiratory diseases. The important ones that I'm going to talk about are hypoxia and respiratory failure, bronchiectasis, and ARDS, or acute respiratory distress syndrome. So firstly, hypoxia and respiratory failure. The two principal mechanisms by which pulmonary disease may lead to hypoxia are ventilation-perfusion mismatching and alveolar hypoventilation. In ventilation-perfusion mismatching, there's an imbalance between ventilation and perfusion, such that blood leaving the affected part of the lung is poorly oxygenated. Alveolar hyperventilation, on the other hand, describes a situation where there is a global reduction in the amount of oxygen delivered to the alveoli due to inadequate ventilation. The most useful way to distinguish between these is by doing an arterial blood gas and measuring the partial pressures of oxygen and CO2. The concept of respiratory failure is used to further classify hypoxia. Respiratory failure in general is defined as an arterial PO2 of less than 8 kilopascals and is a dynamic process, with patients often moving in and out of this state. The figure of 8 is important as the percentage saturation of hemoglobin falls precipitously as you go below 8. The two types of respiratory failure correspond to the two processes we referred to earlier. So type 1 respiratory failure, defined as, of course, a low PO2 less than 8, together with a normal or low PCO2, corresponds to diseases which cause ventilation-perfusion mismatch, for example, severe pneumonia, pulmonary embolism, acute asthma, pulmonary fibrosis, and acute left ventricular failure. Blood-leaving alveoli with mismatched ventilation and perfusion will have a low PO2 and a raised PCO2. However, in this condition it's possible to increase ventilation to normal areas of lung to remove the excess carbon dioxide, but not possible to compensate for the lowered PO2 because the hemoglobin leaving these normal areas will already be 100% saturated. Contrast this to type 2 respiratory failure, defined of course as a PO2 less than 8, but together with a raised PCO2. This tends to occur due to generalized alveolar hypoventilation, resulting in impaired transfer of both oxygen and carbon dioxide. Common conditions causing this type of respiratory failure are COPD, neuromuscular disorders impairing ventilation, and importantly, a severe acute asthma attack where there is significant tiring due to hyperventilation. This application to asthma also illustrates that many conditions can cause both types, and patients may swing between the two. It's also important to understand that respiratory failure may be acute or chronic. So in acute respiratory failure, say caused by pneumonia, PE, or acute asthma, there is a sudden reduction in lung function that returns to normal when treated. However, in chronic respiratory failure, most commonly due to COPD or pulmonary fibrosis, there is often compensation with relatively few symptoms. However, there are some important sequelae. These are pulmonary hypertension due to persistent constriction of pulmonary arteries, and secondary polycythemia, which is a response mediated by the kidneys with increased production of EPO and a resultant increased red blood cell production. So I'm now going to talk about bronchiectasis, another end-stage complication of a variety of lung disorders. Bronchiectasis is defined as abnormal permanent dilatation of the airways, and the most affected ones are those of the third and fourth generation. The basic pathophysiological mechanism in bronchiectasis is persistent destructive inflammation in the walls of the airways, resulting in a self-perpetuating cycle of obstruction and infection. Bronchiectasis may be localized or diffuse. Localized bronchiectasis is most commonly seen as a complication of either obstruction to an area of the lung, say a tumor, or as a sequel to a focus of severe pulmonary infection, particularly one arising during childhood. Diffuse bronchiectasis, on the other hand, is almost always due to a result of inherited disorder predisposing the lung to repeated infections. Two important examples would be cystic fibrosis and inherited disorders of ciliary clearance, such as cartilaginous. Clinically, there is usually a persistent cough with sputum that is characteristically offensive. So the last end pathway I'm going to talk about is acute respiratory distress syndrome, which implies sudden, very severe lung damage. Other names for this include acute lung injury, shock lung, and histologically diffuse alveolar damage. Important causes of ARDS are sepsis, so a severe pneumonia or septic shock, severe traumatic injury, which may be either pulmonary, such as pulmonary contusion, or multiple fractures, or just generally very severe sudden onset trauma, or multiple blood transfusions. There are three important disruptions that occur, and these all happen in elements that compose the alveolar capillary barrier. Fluid leaks into the alveolar spaces, causing a pulmonary edema. Fibrin leaks into the alveoli, forming hyaline membranes. If you remember hyaline membrane disease in neonatal respiratory distress syndrome. And surfactant is lost, so there is alveolar collapse. Collectively, all three features result in impaired transfer of gases in and out of the lungs, and of course associated extreme breathlessness. Mortality is around 50% in this condition, with the remainder of patients often having severe morbidity and residual disability.